People usually hate it, but I like it. Okay.
Yeah, I know. You
So
how much you love it.
I don't know why. I just like it so much. Okay. So we're going to talk about basic fluid balance first. So this is a blood vessel. Okay. And then you've got your capillaries right here. And then you've got your cells right here. Okay. These could be heart cells, kidney cells. It doesn't matter. Any cells in the body. Okay. So in order for your body to live, your cells have to live. Yes. All right. So your cells require certain things in order to live. It's the same things that we require to live, right? Glucose, sugar, right? Oxygen, water, electrolytes. Those all have to come through your blood, down the capillaries, into your cells. Your cells eat, drink, whatever, and then they pull the fluid back and replace it. Okay?
Pull the fluid
Back into the vessel.
Okay.
Because we need, blood goes through your vessels and you need that, but the stuff doesn't do you any good in the blood. You need it in the cells, right? Okay, so here's how it works. So as your heart pumps, right, it's going to pump out the aorta, yes, and then down to your blood vessels. Okay. So this is going to go through a blood vessel. There has to be some kind of pressure to push the blood down the capillaries and into the cell. That's called a hydrostatic pressure, right? Oh, okay. So the hydrostatic pressure, think of it like a big water hose, like a big fire hose. Okay. It's meant to have a lot of pressure behind it so that that blood, when it comes through here, whoosh, will go down into here so that your cells can get the water and glucose and electrolytes out of there, okay? Then after the cells eat, right, and you have other stuff inside of here too, right? Yeah, so this is intravascular. So intra means inside, right? Vascular means vessel. So intravascular means inside your blood vessels, okay? Intercellular, intracellular. So intra means inside the cell, okay? And then you have your extracellular fluid. Extra just means outside. So extracellular fluid is anything outside the cell. That could still be intravascular, could be interstitial. Yeah, because it just means anything outside the cell. Exactly. And then interstitial is where you still need fluid in here because you still it can still travel down in here, right? You have tissue and stuff inside of here. So let's say you burn something here, like you burn yourself with a curling iron or something, right? You still have to have fluid that goes down here to get white blood cells and things like that. So interstitial fluid is normal fluid. Okay. So we're pushing blood down here. It goes into the cell. It eats and drinks, right? And then it's going to go through the interstitial. It's just going to kind of do its thing down here. And then when it's ready, like if there's excess, which there always is, right? Your cells are usually pretty hydrated. Then you have to have some kind of pressure to suck it back up into the vessel. And that is called colloidal osmotic pressure. Okay. Colloidal osmotic pressure. Now, I remember this, a pulling pressure, because who pulls you over? A cop does, right? So colloidal osmotic pressure is a pulling pressure, and it will pull the fluid back into the vessel. It will get replaced with glucose, electrolytes, yada, yada, right? And that's how the basic fluid balance works. And this is happening all over your body all the time. Okay. Blood comes through here. Hydrostatic pressure pushes it into the cells. We eat. We pull back up by colloidal osmotic pressure and go back out to the rest of the body. Okay. So that's basic fluid and how it works. Now, you were talking about labs and how that was confusing for you. So let's fix that. In the intracellular space, so anytime we're drawing labs, okay, like if they say, hey, I need you to go draw electrolytes on this patient, right? I'm gonna stick a needle in their vein, okay, that's inside a blood vessel. So when we're drawing serum levels, that is coming from a blood vessel. So I stick a needle inside their blood vessel, right, a vein, and I pull out fluid and then or blood and they test it, right? Okay. So when we look at our numbers, all right, so I'm gonna write them up on the board. All right, so normal sodium is, and I write them down for you somewhere else. So you don't have to write them.
Yeah, it's 135 to 145.
Yes, 135 to 145, and then you've got calcium, which is
is it 5 to 8.5?
It's 8.5 to 10. Everywhere. Let me say this
because that's what it says.
Everywhere you look, you're going to have different resources that are going to tell you something different. So what I'll teach you in here is the basic norms, and then when to do something. Because the majority of your questions are not going to come. They're not going to ask you what is a normal sodium level. No. They're going to say, what do you do if a patient's sodium level is 150? So that's what I'm going to teach you, because they don't teach that very well in nursing school. They don't teach you what to do. They just teach you what's normal and what's abnormal. Okay.
But the questions are all like that, though.
Right. So, you'll know what to do. Okay. And you'll know when to do it. Okay. All right. And then you've got potassium level, which is, I'm just going to just jot these down. So, and I'm going to show you what I mean. Okay. Sorry. It's 5. Sorry. That's my bad. I was thinking about something else. Okay. And then mag. Go on.
Is it 1.3 to 5?
I'm going to show you these. Okay. So mag, these are how I remember them. Mag, I start at the bottom. Okay. Mag is 1.5 to 2.5-ish. Okay. You're going to take that number and you're going to put it right here. 2.5 to 3.5 is your phosphorus. Then you're going to take that number and put it right here. 3.5 to 5. Okay, and those are your bottom three that are very low. Now, why did I draw this out for you? Okay, when I'm drawing a serum level of electrolytes, right? And I get the report back. Does this mean, and let's say their sodium level on the report is 138 and their potassium level is 4.0. Does that mean I have more sodium than I do potassium in my body?
Wait, you have more? Well, they're both normal.
They're both normal, but I mean, just look at the numbers. On my sodium reading, it says 138. On my potassium reading, it says 4. Does that mean I have more salt in my body than I do potassium? No. What it means is, I know, this is the way to remember it. So what that means is when I'm drawing a level, I'm drawing from a vein. So let's look at our vein. What is the predominant electrolyte inside my vein? You have a lot of sodium that lives inside of there.
Yeah.
Okay. My predominant electrolytes intracellularly are potassium, mag, and phosphorus. They live inside the cell. Sodium lives in your vascular space.
Yeah, outside.
So when you draw levels, it doesn't mean I have more sodium than I do potassium, but I'm drawing from a vein. So of course I'm going to pick up more sodium because the potassium, phosphorus, and mag are in my cells. And I can't measure something inside my cells because there's billions of cells and I can't go in there. So any of the numbers that are very low, that means they're predominant intracellularly. They live inside the cell. If they have a higher number, then they live in the vessel. Yeah. Does that make sense? Okay.
So that's outside.
Yeah. So calcium lives a little bit in both, right? Because it's kind of in the middle. Sodium, there is some inside your cells, but most of it you can see because it's 135 to 145, lives inside your vessels. Yeah. Potassium always wants to go home. It's a homebody. If it ever has a chance to go home, it's going home. Okay. So anytime you open the door to the cell, it's going inside. Like if you give a patient insulin, like let's say they're diabetic and you give them insulin, we know insulin opens the door to the cell. Okay. Well, glucose will go in, but potassium's like, my door's open at my house, I'm going in. And it will go in. So insulin and potassium go on a seesaw. If you give insulin, it's going to cause your potassium to tank because it's not in your vessel anymore. It goes inside your cell.
But is that a bad thing?
It depends. If it still ends up being normal, then it's fine. Right? But a lot of times if we give insulin to a patient, you have to watch their potassium levels. And you would have to know that that's why fluid and electrolytes is so important. Because we give insulin to everybody. Yeah. I know, right. Yeah. So that's why those kind of seesaws are really important. Okay, so does this make sense? This part. Okay. All right, let's keep moving. Okay, a couple of terms that you need to know. The third space fluid. Now that's not normal fluid, right?
Right. Yeah.
Third space fluid is trapped fluid, right? So it's fluid that, okay, so something came through here, the blood came through here, went down in the capillaries, went through the cells, but it was coming at such a high rate. So either it was coming at a high pressure or you just had a lot of blood.
So is that like where it's in the ascites?
Ascites is part of third space. Any edema, dependent edema, paraorbital edema, you'll see it around the eyes. But this is any third space fluid, anything. So it can start out with something very small. Like a mosquito bite is third space fluid. A blister is third space fluid, right? Because anytime your body knows something's wrong, it says something is wrong, and it vasodilates that it can get stuff to the area, right? Did you see that on the video or no? There should have been an I think it's called inflammation. I think there's 4. Hold on, let me pause this for a second. Okay, so third space fluid is any fluid that's anywhere that it doesn't belong.
Yeah.
Okay. And there's all different kinds of places in your body that can fill with fluid when your body says that there's something wrong. That's what inflammation is, right? Your body says something is wrong and it vasodilates, it opens your vessels so that it can get stuff to that area faster. But anytime you change pressure in your blood vessels, whether it's higher or lower, your body panics and it dumps fluid into the third space. And the reason it does that, any instance you change, because what happens is if your blood pressure goes low or it goes high, your body realizes something inside of me is wrong. And so it thinks maybe my cells are injured and they need something from me. So it will dump fluid. It will increase your capillary permeability, thinking it's helping you. But then your cells are like drowning in the fluid and there's not enough colloidal osmotic pressure to pull all that fluid back into the vessel. So it sticks around in the third space.
So with hypotension and hypertension,
Fluid, yes.
See, that's what I was looking at because it's like I was getting confused. I was reading the book and I was like, wait, it sounds like you can have edema with.
Yes. Yes. And like if a patient is, have you heard of a patient being like septic? A sepsis patient. Okay, so that's when they get bacteria all through their blood. Their entire body says something is wrong and it massively vasodilates, but that drops their blood pressure so low. And then they just third space, and we can give them fluids and fluids and fluids, and it's just going to go right into the third space and right into the third space. Okay. So now usually for first semester, if they say that there's edema, they want you to think too much fluid.
Yeah.
Okay.
But it's like I was reading stuff,
Mm-hmm.
and maybe watching the videos, I was like, wait, it sounds like it could be both.
Yes, it can be both, but they're just trying to keep it super simple for first semester. And they're just like,
Okay.
oh, usually edema means fluid volume overload. And it usually does.
Okay.
But when you get into your complicated disease processes, I mean, yes, hypotension, but the hypotension is because of the third space. It's the opposite way. So if your patient has hypertension, it's going to cause all that fluid to go into the push really hard into the third space. Hypotension is usually because something in your body is wrong. You vasodilated, you change the pressure, and so your body panics and dumps fluid into the third space. Okay, does that make sense?
Okay.
All right. So that's third space fluid, and that could be anything from edema, ascites. I mean, literally, you can have third space fluid
So, but most
literally
likely
anywhere.
when they say like hypervolemia, I mean,
They're going to say edema.
yeah,
Yes.
they're
If they say
always
hypovolemia, now here's, oh, that's a good distinction. If the patient has hypovolemia, like they truly have very little blood volume, they won't be third spacing because there's nothing to third space,
okay.
right? But if a patient has some kind of really bad bacteria or something, they're going to start third spacing their fluid because their body knows something is really wrong. That will cause hypotension in that patient. Okay? All right. So I put a couple definitions on here just because I've seen them test on it before. But osmosis is just water passing from high to low concentration. That's it. Okay. Osmolarity, people get confused on this. So the actual definition is concentration of particles in a solution. Basically, what that means for nursing school is how salty or how sweet.
So that would be hypertonic or
Mm-hmm. Yeah, or they may ask you, what do you think the serum osmolarity of your patient is? Okay, so just take the word osmolarity and replace it with saltiness. Okay.
Oh, okay.
So let's say your
Okay,
patient
okay.
has, they may say your patient has a sodium level of 160. What is their serum osmolarity, high or low?
Hi.
Yeah, so they have a high osmolarity. That's how salty they are. It's that easy. Yeah, that's easy. Yes. I know. It's just that's I think that's why I like fluid electrolytes because it's easy. Sure. Yes. I see patients from everywhere. I mean, sorry, I keep saying patients. Sorry. Um, they each have their own major issues in their own ways. I feel like, and this is my, we understand osmolarity. That's easy. Yes.
Right,
Okay.
saltiness.
Yeah, saltiness. That's easy. All right, and then diffusion. This is, I mean, high to low concentration. Everything in our body goes from high to low concentration. It will always go the easiest route, right?
Yeah,
So if we're in high
exactly.
con, they always do the easy thing. Oh, I want to go to low concentration. That's easier. All right. Active transport is when something requires energy to go across a cell membrane. So in our cells, right, these are not usually permeable, right?
Right.
If something wants to enter your cell and either attack your cell or do something inside the cell, even if it's an electrolyte or something, it has to hop on the back of somebody else.
Oh,
Okay.
yeah, we learned that in anatomy.
Yes, this is like these are old concepts. I just
Yeah,
wanted to
this
make
is-
sure
this
that
is
you knew
anat-
what they meant.
yeah,
Yeah, these
yeah,
were basic.
anatomy.
Yeah. All right. When you are assessing hydration, so this is your basic nursing assessment. If they say like, how do you know that a patient is well hydrated? These are the things I'm going to do. So I'm going to test their skin turgor. How do you test skin turgor on someone? So you're going to pinch up the skin either on the clavicle. On babies, we do it on the abdomen.
Oh,
Okay.
They just taught us
Yes,
that.
clavicle's good. Yeah, I agree. Because in older people, sometimes this doesn't work very well. So clavicle's usually better. Thinner, yes. So you're gonna pinch it up, and if it stays pinch, right, that's called tenting. It makes a tent.
Yeah.
Okay, yeah. So if they have poor skin turgor, that's a sign of dehydration, right? And then tongue turgor, does their mouth feel tacky? They call it tacky. That pasty kind of feeling because your spit is thick. And then ask them, is your mouth dry? And you can look in and see that their mucous membranes are very dry. Okay.
Oh, okay. What does it look like with dry? Just is the color?
There's no spit. You know how like when you pull this down, you can see like it's like wet.
Yeah.
There isn't any. And sometimes their tongue may look kind of like white, you know, because it's like thick spit. Yeah. Presence of tears. So we ask this a lot in kids. When your child is crying, are they crying tears? Because as your body gets dehydrated, it has to conserve that fluid. Okay. Eyes. Your eyes are the window to the soul. Okay. So eyes tell you a lot about hydration status. Okay. So because there's a huge orbit, this is a big space here, right? So in order for you to be dehydrated and to show sunken eye, you'd have to be very dehydrated because it's a very deep pocket, right? So it's yes, it's pretty bad. And then on the other side too, these can get very puffy. We know that. We get puffy eyes underneath, right? Because you don't sleep well or what have you. So these tell us a lot about hydration. Yes, because that's fluid volume overload. So right here, if it's puffy or edematous, they're usually in fluid volume overload. If it is sunken, that's dehydration or fluid volume deficit. Okay. Edema, we talked about that, right? So if they have edema, that could go one of two ways, right? If they have edema, I know. So if they have edema, that could mean that they were already in fluid volume overload. Okay. So if I see jugular venous distension and bounding pulses and they have edema, I know they're in fluid volume overload. Okay. If I see edema and I do their blood pressure and their blood pressure is very low, then I'm like, something really bad is happening in your body and your fluid is leaking out to the third space. Okay. But if they have hypovolemia, they will not have edema because there's no fluid to leak. Okay. Is that worse? Yes. Yes. Because that usually means sepsis, shock. Like those are bad situations. Or if a patient had a major trauma, like they got a gunshot wound, stab wound, something like that, and their body's like going through a massive thing, it's going to third space all that fluid. Okay. All right. And then we're going to look at body temperature. So as you start to get really dehydrated, you're going to get very cold because you don't have very much blood left, right? So they may feel cold. Urine output. So this is very, very, very important. Urine output and daily weight. Okay, for all of nursing school, as far as hydration status, you will always pick daily weight. Yes. Over isonos. Yeah, because lots of things can happen. You could have bad kidneys and that cause you not to have good output. It doesn't tell you your fluid balance status. Okay. If somebody gains 5 pounds between one day and the next, that's not weight. That's fluid. So that tells me, oh, crap. But if you have third space fluid or edema, they may not pee very much. Right? So urine output doesn't always tell me everything I need it to tell me. I need to know their weight. Okay. But urine output is something, of course, that we look at. And then heart rate and blood pressure. So as somebody gets dehydrated, their blood pressure is going to start to go. Yeah, it's going to go down, and their heart rate's going to compensate by speeding up. So hypotension plus tachycardia always go together because your heart will always take your side. Okay, I will help you. All right, so you understand hydration status. All right. Labs that could indicate dehydration in your patient. All right, so we've got the hematocrit. Do you know anything about hematocrit? That's the HCT.
I know it's normal, like between 12 and 16.
That's the hemoglobin.
Oh, that's hemoglobin.
Yeah, but it's the same concept. So hemoglobin and hematocrit. No, I will sometimes forget that you're in first semester. Yeah. If I ever say something that you don't know, just say like, oh, I haven't learned that yet, and I'll be like, oh, okay, okay, because sometimes I forget what people know, what they don't know. Okay, so hemoglobin and hematocrit are both found inside your oh, you know what you need to do? Let me do this. I'm going to do very quick this with you, but write yourself a post-it for homework. On the YouTube channel, there is a video called Decoding Lab Values. You left-handed? Look at you go. Okay. It's called CBC. It is CBC. It will be invaluable for you all through nursing school. So to go through every component of what we find in a complete blood count and then how to apply it to your patient. Okay. So hemoglobin and hematocrit are in a CBC and they tell me basically the oxygen carrying capacity of your red blood cells. Okay. So on your, and there's a video for this too. Another video on the fluid and electrolyte playlist. Okay. But I'm just going to explain it to you really quickly. On every red blood cell, there are 4 seats. Okay. And your hemoglobin sits in each of these 4 seats. So we've got 4 seats that are the hemoglobin, right? Okay. Now you have to have hemoglobin on your red blood cell in order for oxygen to sit in the chair. Okay. So there are 4 seats here, right? So hemoglobin is the chair that you can sit in. The oxygen will then have to come and sit on this chair. Okay. This is where we get your pulse ox from, that little thing that goes on their finger.
But if there isn't any oxygen or hemoglobin in one of those seats.
If there's not any hemoglobin on the red blood cell, yeah, you can't oxygenate because oxygen won't have anywhere to sit. Okay. So the hemoglobin tells me how many seats are available. Okay. And the hematocrit is the percentage, I'm going to give this to you, of those seats, okay, that are saturated with oxygen. Okay. So
that's what I meant. So if like one of the seats isn't saturated.
Yes. And look at the average because it's reading all your blood through your finger. Right. Okay. So here's your red blood cell. Yes. You have 4 seats. 1, 2, 3, 4. That's your hemoglobin. Okay. Right. Now oxygen, as it goes to the blood, can come and sit and occupy one of those seats. Right. Then we put the pulse ox on the patient,
Right.
and it reads millions of these at one time. And it gives me the average of how many of these seats are occupied.
Oh,
Okay?
okay.
So an SpO2, which is your pulse ox, is in a percentage, right?
So
If
when it says
I,
95,
that
98,
means that 95% of their
Right.
hemoglobin seats are occupied with oxygen. Does that make sense?
Yeah.
And there's a whole video that I do on the red blood cells. Yeah. So that's what happens. That's what the hemoglobin is, and then the hematocrit is the percentage of oxygen that's saturated. Okay.
Okay.
All right. So that tells me. That's why I think I did pulse ox to somebody else. Oh, I erased it already. That's why a pulse ox gives me a percentage, because what's the percentage of these that are saturated? So hemoglobin and hematocrit tell me basically how well are your red blood cells carrying oxygen. Okay. All right. So, but let's apply that here. So, a hematocrit is a percentage, right? And a hemoglobin and hematocrit, you're looking at how concentrated your blood is, because inside your blood, we're made up of salt water. We know that, right? You bite your lip or something, you taste it, it's salty. So we're made up of salt water. That's because salt lives inside the vessel, right? So that's why blood tastes salty, right? Okay. So, but we're also made up of solid and liquid. So inside our blood, we're made up of the liquid portion, which is plasma, right? Okay. Now, what makes our blood red? Red, right? The red blood cells, right? So red blood cells are solid. I could hold red blood cells in my hand. They're teeny tiny, but they are solid. Okay. So when you're looking at hematocrits, right, and hemoglobin, you're basically looking to see what is the percentage of water to my red blood cells, because I've got liquid and I've got solid. Okay. If a patient is very dehydrated, they're going to have very little water. Did I change my number of red blood cells? No, but I took away so much water, so their hematocrit is going to look increased, because their blood is going to be more concentrated because I have more red blood cells. That's why in dehydration, you'll see the hematocrit will look increased. That's called hemo concentration. Hemo means blood. Your blood is just more concentrated. Does that make sense? So if I did a CBC and I got the hematocrit and it's like 58%, then I'm like, okay, either your body is making tons of red blood cells, which isn't very common, or you're just dehydrated. Drink some more water, you know? All right. Another indication that the patient is dehydrated is the urine specific gravity. Okay. So this should be urine specific gravity is basically either how clear or how concentrated your urine is. And when you're dehydrated, it's going to conserve all the water it can. So when your urine comes out, it's going to be thick, which means your urine specific gravity is going to be high. Okay. So the higher it is, the more concentrated, right? So a normal urine specific gravity, I think I covered this for you somewhere else, but just in case, is 1.005 to 1.035. Now, also, I like to remember with a urine specific gravity is a specific gravity, urine specific gravity of water, plain water is 1. Okay. So the closer it is to 1, the clearer it is, because that's water. The farther away from 1 it is, the more concentrated it is. Okay. All right. Then you've got BUN and creatinine. Do you know anything about these two?
They haven't really
talked about them. Okay, we'll talk about them quickly. So the BUN stands for blood urea nitrogen, and CR is creatinine. Okay, these are what we call your kidney functions. So if we ever say draw kidney functions, that's what we're talking about. They're 2 waste products that your kidney is responsible for getting rid of. Okay, so as your body burns protein, like, you know, you eat, I don't know, you go to the rodeo and eat turkey leg or something, your body burns that off, and that byproduct is called blood urea nitrogen, just a byproduct of protein breakdown. Everybody has it, right? But your kidneys are supposed to get rid of that waste product. Okay. Then creatinine is the byproduct of muscle breakdown. So as we run or we walk or we just do basic things, our muscles have some breakdown. And the byproduct of that is called creatinine. Okay. It is normal for your body to have it, but you have to get rid of it through your kidneys. Okay. So BUN and creatinine live in your blood. All right. My kidneys are supposed to get rid of it. So if for whatever reason, like I am very dehydrated and my kidneys are not, they're having to really overwork, they're not going to get rid of your BUN and creatinine. So you may see those start to increase.
And what happens is if you're running creatinine,
you're going into kidney failure. Okay, because this is very rudimentary and I cover this on another video, but let me just show you this. Okay, so if your body is starting to not have enough fluid, okay, it has to make some decisions where it's going to give fluid, right? Like, let's say I only have a certain amount and I'm like, it's not enough to give perfusion to my whole body. I need to pick which parts I'm just going to let die. Okay. And the first place that it's going to let die is your arms and your legs, because you don't have to have those in order to live. Okay. So it'll start pulling blood away from those first. Like, let's say my blood pressure goes to like 88/40. I don't have enough pressure or blood. So my body's got to be like, look, she has to have her brain to survive. She's got to have her heart. She has to have her lungs. I don't have to have arms and legs. I mean, that'd be a bad life. It'd be a rough life, right? But it's doable.
Yes.
So when you go to assess a patient that is very, very dehydrated, I'm talking very dehydrated, okay? And their body had to make that decision, their pulses will be very weak because that's extremities. They're going to feel cold. Their capillary refill is going to be very increased. That's called signs of poor perfusion. Their arms and legs are not getting perfusion because your body decided it was more important to get the blood here, here, here. Okay. After it pulls away from arms and legs, it has to make another decision because your blood pressure hasn't changed. Okay. So it's like, all right, out of all these organs, which one am I going to pick to pull blood flow away from? Will my brain recover? No. Will my heart recover? Nope. Will my lungs recover? No. Will my kidneys? Yes. They are one of the most resilient organs. Okay. So it will pull blood flow from your kidneys next. That is called shock. Okay. You've heard people say, oh, the patient's in shock.
Yeah.
It doesn't mean like, oh, they're surprised. Okay. It means like, because you asked me what's the consequence. The consequence of low blood pressure is your body made this decision first, pull away from arms and legs. Then it had to make another decision and it's going to pull away from kidneys next. Okay. And when it does that, you're going to go into kidney failure. Okay. Now our job is to get you rehydrated as fast as possible so you don't go into hypovolemic shock. Okay. So the word shock just means your kidneys are not getting perfusion. The word we put in front of it is how they didn't get perfusion or how they didn't get blood flow. So in this case, it would be hypovolemic shock. But there's also septic shock, right? There's cardiogenic shock. There's anaphylactic shock. Okay. So let's walk through just a couple of those really quickly. So you know what anaphylaxis is? Allergic reaction, big allergic reaction. Okay. So let's say your patient is allergic to peanuts, right? And they go and they accidentally eat a peanut. Okay. Their whole body is going to say something is wrong and they're going to vasodilate, right? Which is going to cause their blood pressure to drop. And anytime you change pressure in a vessel, your body leaks into the third space. That's why when they're going in an allergic reaction, what do they look like? They're swollen. Their eyes are runny. Their nose, that's third space fluid. Okay. So when a patient's in anaphylaxis, their blood pressure is like 80/40. Then their body has to make some decisions. It's going to pull away from arms and legs, and then it's going to pull away from kidneys second. That is called anaphylactic shock. Does that make sense? Okay. Then you've got septic shock. So you already told me you knew what sepsis was. So it's bacteria in the blood. I mean, your blood is everywhere. So your whole body is going to say, something is wrong. There's bacteria in here. You're going to vaso. That's going to cause your blood pressure to, anytime you change pressure in a vessel, your body says, something's wrong, and it leaks into the third space. So if a patient is septic, their temperature is 103, right? Their white blood cell count is really high. I'm going to go check their blood pressure. I already know their blood pressure is going to be 90/60. I can give them all the fluids in the world, and guess where it's going to go? That's why sepsis is so hard to treat. Okay. So then it's going to pull away from arms and legs first, and then it's going to pull away from their kidneys, and that's called septic shock. Yes, but it's very difficult because we can give fluids, and we can't. And now your kidneys either are going to come back or they're not going to come back. And then the second thing that happens with septic shock or sepsis is once that bacteria die, like we give you massive antibiotics, they have like little knives inside of the bacteria that come out whenever you kill the bacteria, and that goes and deposits all in your blood vessels. So it's very difficult to treat, but possible. All right. I hope that answered your question. I probably went too far into that. Okay. Dehydration, less than 30 mLs per hour of urine output. So that's the minimum for all of nursing school. We want at least 30 mLs an hour of urine output. So if they go below that, it's not very much. That's a very minimum. That's giving just enough to prevent shock. That's making sure your kidneys are getting enough. Is like your kidneys are probably not going to do very good. Okay. Do these labs make sense? Okay. Does this page make sense? Good. All right. Let's move on. All right, let's go to your cheat sheet.
This is good because I am like.
Did I give you a cheat sheet? Oh, nope, I didn't. Here. Okay, there's your cheat sheet. All right, so we'll go over the basics of this one.
Okay, oh, this is good.
Yeah, I think this will be helpful for you.
That's really good.
Okay,